Hi there, I am Dr. Ajay Arora, and today, in continuing our basic lectures of retina, we'll be discussing on fundus fluorescein angiography. So, this lecture is targeted towards fellows or postgraduates who are starting the journey of retina, but it may also benefit some others who have already begun the journey and wanted to just brush up. So let's get started. So some definitions first. Now, what is luminescence? Luminescence is when an electromagnetic radiation is absorbed by a substance and emitted at another frequency. Now, fluorescence is luminescence, which is maintained by continuous excitation. Here there is a lower wavelength, that is blue light, which strikes the unbound fluorescein and is emitted at a higher wavelength, which is greenish yellow light. Okay. So it's at a lower wavelength light, which is the excitatory light, blue light, which hits sodium fluorescein, and you get a yellowish green light. Now, what is pseudofluorescence is when a non-fluorescent light passes through the entire filter system. That means it doesn't get blocked by the barrier filter. Then it is called as pseudofluorescence, and this has been the basis of fundus autofluorescence. Autofluorescence is emission of fluorescein in the absence of use of sodium. So here you can see that the blue light, which stimulates the sodium fluorescein, which is in the retinal circulation, and that causes emission of a greenish hue light, which passes through the barrier filter and is taken up by either a film, which was done in the past, or by a digital camera. So this is the dye being injected in the antecubital vein. It can also be injected on the dorsum of the hand. And then we look at the circulation of the dye within the retina. It can be done by the normal fundus camera, which gives us a view of about 50 degrees, or it can be done by an SLO-based machine like the Nidec Mirante, which covers the entire field. Now, just a word about ICG angiography. ICG, the excitatory beam is between 790 to 805 nanometers, and the emission occurs at about 835 nanometers. Now, let's look at fluorescein angiography a little bit more. Sodium fluorescein is basically a safe drug. It can temporarily cause tan skin discoloration of the skin, which is temporary, of course. The urine that day will be yellowish green in color. You must tell the patient, because the patient goes home and suddenly finds the urine to be yellowish green, and the patient gets very disturbed. There may be transient nausea and vomiting, and whenever this starts happening, I tell my patients to deep breathe, do a deep breathing while the procedure continues. In more severe cases, patient can have asthmatic symptoms or a laryngeal edema. Now, the dye is metabolized in the liver and excreted by the kidney. You have three concentrations available. 20% you inject 3 ml, 10% you inject, and 5% you inject 10 ml. What we normally do is to inject either 20% or 10%. Now, some people inject directly with a needle, which I do not think is the correct way of doing it. Others use a Ventlon, so you put in a catheter, or sometimes you can do that by putting a scalp vein. But please be very, very careful that once you put the needle in the vein, make sure that you're totally in the vein, because if you inject the dye outside the vein and it causes a small amount of hematoma there, is going to cause a lot of pain. So you should avoid having any hematoma. Now, how do we go about doing it? We take the consent of the patient, have a good pupillary dilation, ensure that all the emergency drugs are in place, get a venous access, and then we load the dye in a syringe. We also simultaneously load injection decadron, and we go about taking the color fundus photograph, the red-free photograph, and the moment we start injecting, we take a photograph again. And then we again take a photograph at the end of the injection period, and then we keep taking a photograph every minute, every second for the next 20 to 30 seconds. And after that, we go on to the other eye. We should follow the ETDRS protocol for the areas to be clicked, and the entire process takes about 5 to 10 minutes. Rarely late photos are required. So let's look at how to be prepared for any eventualities when procedure like fundus fluorescein angiography is done. We must have an amber bag with a face mask, PP apparatus, oxygen cylinder, airway, endotracheal tube, laryngoscope. Then we should have the IV fluids, 5% dextrose, ringer lactate, normal saline, soda bicarb injections, injection adrenaline, injection Lasix, hydrocortisone injection, aminophylline, Avil. And of course, you should have the MSS tray or the dustbin. Patient must be fasting for at least about 1.5 to 2 hours, or maybe 2.5 hours also. Well-dilated pupil, and should not have any documented allergy to iodine or fluorescein. Now, before we take up the patient, you must ensure that the pupil is well dilated. Otherwise, you'll not get good images. Patient should be seated comfortably in front of the camera. I would always prefer a headband, because otherwise patient keeps moving backwards or sideways. And the height should be adjusted well so the patient is comfortable. We should have a bin ready by the side of the patient, so that if the patient vomits, the patient should not vomit on the equipment. The patient should vomit in the dustbin which is provided for it. And you should be ready with your emergency kit. Take the red-free photograph, and then you start injecting the dye. It can be either injected on the dorsum of the hand or in the antecubital vein. You should take a photograph immediately at the time of injection, and then immediately at the end of the injection, and then every second still about 30 seconds. You have to take the fundus photographs as per the ETDRS protocols. And what happens to the dye once get injected in the peripheral vein? It gets into the venous circulation, goes to the right side of the heart, and then to the left side of the heart. And from the left side of the heart goes to the internal carotid artery. And from the internal carotid artery goes to the ophthalmic artery. Now you see here ophthalmic artery, which is dividing into the short posterior ciliary artery, which are about 20 of them around the optic nerve, and a central retinal artery. The central retinal artery supplies is the source for the retinal circulation. So the short posterior ciliary arteries are the source for the choroidal circulation. Now, a little few principles we must know: that when you have a fluorescein injected, 85% of the dye is bound to serum proteins, only 15% is free. There is normally what is called as the inner blood retinal barrier, which means that the normal retinal capillaries are impermeable to fluorescein. So if a capillary is leaking, we must understand that this inner blood retinal barrier has been broken, and there are situations which lead to it, and we'll come to it later on. Then you have an outer blood retinal barrier, which is by the zonula occludens, which is in the, this is the retinal pigment epithelial cells, and between them is the zonula occludens, and this is also impermeable to fluorescein. The choriocapillaries, which is present in the choroid are free to fluoresce. Now, what are the 5 angiographic phases? You have a pre-arterial phase or a choroidal phase, that is when there is a choroidal flush. This happens about a second before the fluorescein enters the retinal circulation. And once it enters the retinal circulation, you have an arterial phase, an arteriovenous phase, a venous phase, and a recirculation phase. So, for example, here, this is the arterial phase. This is the capillary phase or an arteriovenous phase. This is the early venous phase. You can see here that the veins are getting filled up. There's a marked lamellar venous flow. And then you have the mid or the late venous phase. And subsequently, you can have a progressive weaker fluorescence, which can happen at a late stages. Now, let's come to a few definitions. What is hyperfluorescence and what is hypofluorescence? Hyperfluorescence means there is leakage, which means there is an increased amount of fluorescent dye with time, which comes out of from where it is supposed to be and induces the margins to become blurry. Proving there is a rapid filling up of a flow space, and once filled, there is no more increase, like a pigment epithelial detachment. And then you have a window defect, which is a transmitted hyperfluorescence, like indrucence, and then you have staining, like a fibrovascular PED. Now, hypofluorescence, that means there's less dye present, or there is a less detection of the dye. The less dye can be present when there is a vascular occlusion. Less detection when there is blockage by some material present in front of the dye so that it cannot be detected. Or there is a loss of vascular tissue as it happens in myopia. Now, pseudofluorescence, as I told you earlier, is when a non-fluorescent light passes through the entire fluorescent symptoms. Now, let's look at some of the examples. Like this is a cystoid macular edema. You must have heard of the term cystoid macular edema. So there's leakage within the macular area because of the cystoid spaces which get filled up. This is a case of a wet age-related macular degeneration. You can see a membrane which is present in the subfoveal area. So this is a choroidal neovascular membrane. Then you can have prolonged dye retention by staining, and this is associated in cases of drusense. Now, RP window defect, like here you have RP atrophy or the bullseye maculopathy, then you can get a window defect. You can have pulling of the dye, like in pigment epithelial detachment in under the RPE, and this stains uniformly and doesn't increase after that. This is a situation which is under the sensory retina, again, almost similar pattern. So this is the case of a C-fan neovascularization. You can see the hyperfluorescence because of the C-fan neovascularization. Now, this is a little complex slide, but it shows that you have NBD, and this gradually starts leaking, and you can see the leakage is much more at a subsequent time. If we go to the periphery, you can see here, you will suspect these two lesions as hyperfluorescent, and you can correlate these lesions by the angiography as well as clinical photography. This is the case of a CSR with ink blot sign leakage, which gradually improves over a period of time. Again, ink blot. And this is the case of a CSR with a smokestack appearance. Again, a smokestack appearance. Now here you have a lasered wide field photograph lasered wide field angiography, which show you that there are large areas of capillary non-perfusion present. Also, there are areas of NVE present. So these patients, if they are treated well by augmentation or laser photocoagulation, they would rather do well. Otherwise, they can have retinal bleed. This is a patient, old patient of CSR, which shows that there are old tracks which are present and these are getting stained. So it's important that we are able to correlate the colored picture findings with that of autofluorescence, and you are able to decipher things correctly. This is the case of a hypofluorescence. So it can happen because of blockage, because there is blood present under the retinal pigment epithelium. So there is a blocked choroidal fluorescence. But if you have a pre-retinal blood or an intraretinal blood, then you will have a blocked retinal and choroidal circulation. This is the patient post-COVID who had a venous occlusion. So you find here large areas of capillary non-perfusion. And this is because this hyperfluorescence is because of reduced fluorescein which reaches this area. This is the patient post-COVID who had a venous occlusion. So you find here large areas of capillary non-perfusion. And this is because this hyperfluorescence is because of reduced fluorescein which reaches this area. So this is a patient where you can see a blocked fluorescence, and under that you see that there is a blockage because of the presence of heme. So there's a difference between the two. So now let's look at this peripheral exudative hemorrhagic chorioretinopathy. You can see here that there is heme present. You can see here also there is heme present, and then there is some exudates which are present here. This is FA ICG being done. The ICG is able to demonstrate the branching vesicular network. And when we look at the angiogram, you can actually see the retinal blood vessels, but because of the heme, one is not able to see beneath the heme. Only in the ICG one can make out, like in this patient, you can see the same area on the ICG, the branching vesicular network can be made out. Now, this is another patient where there is a pre-retinal hemorrhage, and the pre-retinal hemorrhage causes a blocked fluorescence. So you have a hyperfluorescence because of NBE, you have a hyperfluorescence because of NBD, and you have a hypofluorescence because of the pre-retinal heme which is present, which causes a blocked fluorescence. Now, here you have a leaking microaneurysm. So you can demonstrate the capillary network so beautifufully in the macular area. But the reason why the fovea is avascular, it is because there's a highest concentration of cones, and the light goes unimpeded to the cones here. There are tall RP cells present with melanin that block fluorescein. Hence, and also because of presence of xanthophyll, which block fluorescence in this area. So this is another example of a patient who with proliferative diabetic retinopathy. You can see the neovascularization here, which you can see also on a colored photograph. You can see a hyperfluorescence of this patch here, and you can see a hyperfluorescence here, which corresponds to this patch here. So these are all obvious clear-cut neovascularization which are present. But this area, one would not imagine that there is no blood flow, but when you see here, there's a large area of capillary non-perfusion, which shows that this area is not perfused or hyperperfused. Okay. Now, certain situations, patient may not be willing for an IV angiography because may be allergic to it. You do not wish to give an IV drug. In these cases, one could do an oral fluorescein angiography. So you ask the patient not to eat in the morning, mix 2 vials of 25% fluorescein in a glass of orange juice. Ask patient to drink that with a straw to prevent staining of the tongue. And ideally, this should be done on an SLO-based system. Dye appears within 5 minutes, and one is able to demonstrate fairly good angiogram. So this is the oral FFA. You can see the picture at 12.2 minutes, 18.16 minutes, 22 minutes. So we can actually see the membrane pretty well, and you can see the vessels pretty well, which is quite remarkable that we were able to demonstrate the choroidal neovascular membrane with an oral angiography. Now, you should, whenever we're doing angiography, you must have a plan for each angiogram. Always have a clinical photograph and a red-free photograph before you interpret an angiogram. You must follow a sequence of taking the pictures. Do not interpret the angiogram while recording. Look at it later as a series. Do not talk about the diagnosis, but only look at the findings, the time taken, the delay, the hyper or hypofluorescence. While describing an angiography, you must describe the choroid, disc, and vessels also. Always be ready for an emergency while doing an angio, and for the patient with a renal involvement, take clearance from the nephrologist. Thank you for your patient listening. Thank you.